I said to one of the doctors, I said, "You don't really care that I have numb feet, do you?" And he said, "No." And I'm a runner. I've run 3 marathons, and actually it is a real bother having numb feet. I would rather not have them. So the neuropathies pain can be very significant, and they sometimes aren't that good at figuring out how to treat them, although there are good treatments available. And all of the drugs, all the treatments have side effects. The surgery for breast cancer, you've got pain, you've got numbness, some people have phantom breasts, you have skin changes from the radiation if you had lumpectomy and radiation. There are sarcomas. One of my close friends and a great breast cancer advocate, Carolina Hinestrosa, had a early breast cancer, had lumpectomy and radiation, and got a myosarcoma from the radiation, which is not common, but died from the sarcoma caused by the radiation that cured her cancer. So this isn't a common thing, but it's to say that there's no free lunch. And so the radiation can also cause heart disease, it can cause lung problems. The chemo for breast cancer causes leukemia, not high, but it does have an incidence of causing leukemia. It causes heart disease, neuropathy, chemo brain, which is real, fatigue, fertility problems, as we just heard, and the hormones, joint pain, hot flashes, depression, weight gain. None of these, and most of these are not really dealt with very well by the medical profession. So I think there has to be more of an emphasis as we have more and more survivors living longer on what the price is that you pay for being a survivor and how we can deal with it and how we can ameliorate it, whether it's depression, whether it's hot flashes that are significant and you need drugs for that, whether it's neuropathies. All of these things, we need to have ways of dealing with them, and we need to have ways of talking about them ahead of time as well, which is generally not done. And the other thing I think that is critically important is having the voice of the patient as part of the discussion. I do a lot of talking now in fact, I'm doing one next week where it's this in thing to have these talks where you have a patient organization or somebody representing patients, and then you have the pharmaceutical company, and then you have academics and nonprofits, and how can everybody work together? Well, generally, what the drug companies want is for the nonprofit to deliver patients for them to practice their drugs on, or to give them money to develop drugs to then, and for some of the more rare diseases, the nonprofits do raise money and then invest in drugs that then they come back and test. But I think that what's missing is a voice from the public and the actual patients. It's one thing to have the executive director or the president of the nonprofit up there. It's another thing to have the voice of the people who are actually taking the drugs or actually have been through the disease. And it's not usually the same. I mean, sometimes it is. You have someone with the disease who's the executive director, but often not. And the public voice. So if you look at breast cancer, one of the things, and if I had a slide, I would have shown you that, and it won't surprise this audience, the aromatase inhibitors are drugs that the medical profession thinks have no side effects. I'm serious about it. They really think they have no side effects because, you don't throw up and your hair doesn't fall out, and, and in fact, when you look over time, half the women who are started on them stop taking them within 5 years, often after 2 years. So here's a drug that the drug companies think and the doctors think you're taking, and you're really not. Now, that voice, that word has to get back to them. Or the other side effects that they haven't heard about yet, has to be represented. And this is something that we think is really important in the Health of Women study that I talked about earlier, where we have a lot of survivors, and so we can start collecting the information that's not generally collected about what the side effects are, what the long-term consequences are of drugs, so that we really get an accurate picture of it and not just what's in the electronic medical record, which is now supposedly the answer to everything. But the doctor doesn't ask, and sometimes it's don't ask, don't tell, but those things don't actually get picked up. And so we're hoping to be able to represent what they call patient-reported outcomes. This is the new hot phrase. But it means it's coming from the public. And in the past, they dismissed those. Well, they're not accurate if they're coming from the patient. You know, we can't believe them. Has to be in the medical record, has to be the doctor. But actually, it's more accurate to ask the patient and the public. And I think that's something that really needs to happen, and we need to push for more, because the chemotherapy regimen that I had for the leukemia hasn't changed in 20 years. It's the same one they started out with. Well, that's ridiculous. And it really needs to be looked at and restudied. And the side effects are not insignificant. And they didn't, you know, talk about them a lot ahead of time. So even to me as a physician, so it doesn't help being a physician, I can tell you. So we really have to push, I think, more for that and more for getting our voice out and really complaining and telling them what the consequences are, because they're not going to take them seriously unless we do. And so we have to stop being good little girls and so that they'll like you and really bitch and moan a little bit more. So one way you can do that, you can help me do it for breast cancer patients, is by joining, I'm going to put another plug, the Army of Women. I should put this out there, 444-999. You can sign up on your phone right now and text if you want. Or you can go to actwithlove.org. That's our new tagline, see, because you can walk with love and you can act with love and you can, and then also join the House study, where after a couple of, the first several questionnaires are not about survivorship issues. They're really about the basic stuff you always have to ask, like, you know, how old were you when you had your first period, all that boring stuff. But hang in there, because within a year, we'll be really getting down to the survivorship things. And one of the things, for example, that I'm really excited to look at, I want to look at the people who should have died and didn't. Because we always look at the people who die and why did they die, but we don't look at the people, you know, it's like looking at the airplanes that crashed and trying to figure out why they crashed. What about the ones that got shot and didn't crash? What are they doing different? And how can we learn from that? So we're going to look at long-term survivors and try to see if we can pick up some fancy hints from that as well. Because we look at people, all the studies tend to be early on after your cancer and not, you know, 20 years later. And I think that's going to be really important as well. So join with me. I can't say that I'm thrilled that I'm now a survivor as well as a physician, but I'm thrilled I'm here. So I guess I'm thrilled I'm a survivor in that way. And I do think that it pushes me more than ever to really focus on what are the consequences of these treatments that we so freely dispense. And one of the reasons, and I didn't say it in my earlier talk, I was going to and I forgot, it's chemo brain, it was the problem in breast cancer is we overdiagnose too much. So 30% of DCIS will go on to invasive, but we treat it all like it's bad. We give chemo to everybody to help a few. And when you overdiagnose a lot, then that collateral damage becomes even more important, because they didn't even get anything out of it, you know, and they're still getting all the side effects. So we have to sort this out, or it's not going to be worth it for anybody. So thank you very much.
And we'll get Dr. Love back up here after we have Dr. Spiegel. So it's now my great pleasure to introduce my good friend and colleague, David Spiegel, who is the Wilson Professor in the School of Medicine. He's Associate Chair of Psychiatry and Behavioral Sciences. He's actually also a program leader of the Cancer Prevention and Control Program at the Cancer Institute, and very famous for all of his work, so we'll get to hear it now.
I love surgeons who think about what it means to be human beings and what the treatment actually means to people, and also doctors who are willing to talk about their experience as patients. So I think the Beatles got it right. All you need is love. And thank you for what you do. I also envy Dr. Love her family and her sister donor. Sadly, I lost my sister to a leiomyosarcoma, Dr. Ann Spiegel. She had 2 beautiful daughters, and so I know what it's like from that side too, and I want to mention and honor her in my comments. I'd like to talk briefly about survivorship concerns. I'm glad that survivorship is becoming more of a problem. It means that our cancer treatments, despite everything you heard today, are getting better. So I'll talk a bit about survivorship statistics and concerns, the problems survivors face, some psychophysiology related to stress and disease, and how to handle emotional problems and the possible effects they have on survival as well. And in continuation of what Dr. Love was saying, we often underestimate the constant reminders, and cancer is not a stressor, it's a series of stressors. People live with it day and night, they can't forget it. It's emblazoned on their bodies, and this was one of my breast cancer patients who had been a Silicon Valley engineer and decided when her breast cancer became metastatic that she didn't want to die without being what she'd always wanted to be, which was an artist. So she went to art school, she was teaching art by the time she died, and she dragged this life-size dressmaker's maquette into one of our support groups to remind us what it felt like to live with breast cancer. So she had modified radical mastectomy, a tram flap reconstruction, radiation burns, biopsy scar, and every day she had to live with that, and she wanted us not to forget it. The good news is that the number of cancer survivors in this country is growing. In 1970, there were 4 million. There are more than 12 million now. So the fact that cancer is no longer considered a terminal, but rather a chronic illness, means that many people are living for a long time with it, but none of them are ever truly free of the threat of recurrence or of the consequences of treatment. And the kinds of concerns that they live with include biomedical issues, the kinds of screening protocols you have to go through for recurrence, and also, sadly, for late effects of treatment, the kinds of things Dr. Love talked about. Concerns about chemobrain and cognitive decline, concerns about second cancers that you heard about from Dr. Love, the genetic issues you heard earlier from Dr. Kurian and others that become a problem not just for the patient, but the patient's loved ones. General health maintenance issues, controlling tobacco and substance abuse, diet and exercise, which we're realizing are an increasingly important part of good survivorship. And I tell my patients that you really got to think about being in training. People tend to think when they're diagnosed with cancer, if anything's going to kill me, that's it. Forget about the things you do to protect your heart or other vital organs in your body. In fact, it's even more important, and more breast cancer patients die of heart disease than of breast cancer. So it's very important that people focus on their general biomedical health and safety. There are psychosocial variables as well. Depression, post-traumatic stress disorder. Many people have a kind of PTSD that you see in combat veterans from their own experiences with the life-threatening aspects of cancer. Disruptions in their marriage, social isolation is often a serious problem for cancer patients. And in this country, there are tremendous financial problems as well, insurance discrimination, disability. One thing I can't avoid saying when I talk about healthcare in the United States, you know, the definition of a Canadian is that it's an American without a gun and with health insurance. And the inefficient, horrible, sloppy government health insurance program, Medicare, their overhead rate for managing health care is 2.7%. That means 97.3% go to pay for care. In our sleek, efficient private insurance, medical insurance, the overhead rate is 27%. So government health care management is 10 times more efficient than private health care, and yet we can't seem to get it straight in this country. There have been a number of reports suggesting the Institute of Medicine of the National Academies have pointed out that it is very important for us to pay attention to survivorship care. In this report, Lost in Transition from Cancer Patient to Cancer Survivor, they point out that these issues that I've been talking about must be addressed in healthcare. And there's a new concept now from the National Cancer Institute called cancer rehabilitation. You know, we do this when you break a leg, you get rehab afterwards, and yet we don't tend to think about applying that same model of preparing people, given the treatment and the effects of their injury on their lives, how to live with it and live through the process of re-entering normal life. And that's something we're paying more attention to. In another report, the Institute of Medicine indicated that addressing psychosocial needs should be an integral part of cancer care, and there's plenty of evidence that it works. There is at the National Cancer Institute a division of cancer in the Cancer Control and Population Sciences. Dr. Julia Rowland runs the NCI Office of Cancer Survivorship, which is funding research and helping to change policy and teaching us how to help cancer patients get back to life. This is one of my French cancer patients who depicted her hair loss as being replaced by the crab, the symbol for cancer. And as I mentioned before, cancer is not just one stress, but a series of stressors. Treatment decisions, existential concerns. Everybody who's diagnosed with cancer thinks it's going to kill them, even though more than half of all cancer patients will live to die of something else. They're removed from the flow of life, interruption in family, social, financial roles. And so there are a series of stressors that they need help with when they get back into real life again. And my French patient said that the other problem is your body becomes the enemy. So she says the villain crab goes on the attack here, and many patients have to kind of reconnect with their own bodies because a part of their body has in fact become the enemy. So the fundamental principles of cancer survivorship include recovering from treatment and these trivial side effects that doctors don't worry about too much, watching for recurrence, but remember the rest of your body. And one way I tell this to my cancer patients is do what your grandmother told you to. Eat well, sleep well, and get plenty of exercise. In a sense, you are in training for helping your body to recover from the cancer and its treatment and remain as healthy as possible. So there is more and more evidence now that disrupted circadian patterns of sleep, exercise, and activity not only make you feel worse, but actually may inhibit your body's ability to recover from the cancer. Managing your moods as well. And emotional dysregulation goes with the territory. It's not surprising that cancer patients often feel anxious, fearful, and sad. That's not a problem. It's a natural reaction to the illness and its treatment. Many cancer patients feel punished by their treatment. As you heard from Dr. Love, she said the treatment is hard to undergo. And many feel understandably sad. When your sadness goes from just feeling sad about the disease and its effects to generalizing, to feeling hopeless, helpless, and worthless, you may be suffering with depression. And depression affects about 3 to 4% of us in the general population, about 12% of medical inpatients, and a quarter of cancer patients. And it can interfere not just with quality of life, but potentially with quantity of life too. We published this study in the Journal of Clinical Oncology a few years ago showing that patients whose depression is getting worse over the course of a year, patients with advanced breast cancer, die significantly sooner than those whose depression is getting better, independent of all the other risk factors you've heard about. So and depression is a highly treatable illness with psychotherapy, group support, medication. So not attending to it can actually worsen your chances for survival with breast cancer. And depression can create a kind of vicious cycle where you don't attend to your body, you don't attend to your medical care, you feel withdrawn, you feel bad about yourself, you reduce your connections with other people. And so it's the kind of thing where if you don't get the help you need, you may get stuck in a vicious cycle that doesn't let you pull yourself out of it. In particular, depression, as I mentioned, is treatable with medication as well as psychotherapy, and it may have an effect on the course of life as well. And I want to talk about the kinds of resources, social and others, that we have to deal with problems like depression. We are social creatures. Humans are fairly pathetic physical specimens, but one of the things that helps us survive is our relationships with other people. And there are a number of studies that show that social isolation is as much a risk for mortality as smoking or having high serum cholesterol levels. It may interest you to know that the kind of social support that's good for your health, if you're a man, is being married. If you're a woman, it's not being married. It's relationship with other women, sisters, friends. So it leads me to the unhappy conclusion that having a relationship with a man does your health no good at all, regardless of your own gender, and having a relationship with a woman does your health a great deal of good, regardless of your own gender. But the problem is that when you have cancer, the time when you need social support most, you may get it the least. You're removed from your usual social contacts. You feel like, I'm stuck here with this illness and there are all these happy, healthy people out there in the world. And many relationships, unfortunately, get worse. They either get better or they get worse. They rarely stay the same. So finding ways of maintaining and improving social connections is important for your physical as well as your mental health. I had the opportunity to speak with His Holiness the Dalai Lama, and he made a very interesting point because he talks about compassion and choosing to be compassionate with people you otherwise would have no reason to be compassionate about. And I asked him why he thought that might make people feel better rather than worse. And he said that that experience may be painful, but it's qualitatively different from experiencing your own pain because you're choosing to do it. And in a sense, it's not something that's imposed on you, it's a state of mind that you choose to engage in. And that gives you a sense of control over it that we don't have when we're just dealing with our own pain or that of someone we're naturally close to. And that's why I think there's such power in group support of various kinds, and I recommend people who are dealing with survivorship issues to get involved in a support program. There are many of them. We have them at Stanford, and I'll mention a few in a minute, that help you form social connections, express emotions that naturally come with having had cancer, deal with fears of dying and death, reorder life priorities, improve communications with family and with physicians, and manage symptoms. The idea is to convert anxiety into fear and depression into sadness, to focus on what it is that is making you feel bad, and then you begin to think about what you can do to deal with it. One of the great surprises in my own medical career is that we discovered that helping people do this not only helped them live better, but it actually seemed to help them live longer. So in an original trial of this kind of group therapy, we randomized 86 women, just as you would in a drug trial, to get a year of weekly group psychotherapy, helping people cope with the threat of disease with metastatic breast cancer. And we found, to our surprise, that the women who were randomly assigned to the groups lived 18 months longer than women in the control condition, and they had the same kinds of medical treatment. We tried to replicate that. It only takes about 15 years to do these trials. We didn't find an overall effect, but we found one for women with estrogen receptor negative breast cancer. The ones who were in the support groups lived longer than controls, and what had changed is hormonal treatments for breast cancer. And I see Pat Faubert was one of our co-leaders in the groups there. Women are now living substantially longer because in the interim between the two studies, tamoxifen, the aromatase inhibitors were introduced and improved overall survival, but women with ER-negative breast cancer don't respond to that. There have now been a number of other trials of this. Barbara Anderson in Ohio State found that group therapy resulted in significantly longer survival for women with earlier stage breast cancer. And this is just a follow-up study she did at a 10-year interval. So there are now 15 randomized trials, 8 of which show that getting good emotional support not only helps you live better, but helps you live longer. There are 7, this just summarizes the trials. There are 7 other studies that show no difference. Some of them showed no emotional benefit and also no survival benefit, but I'm happy to tell you that there isn't a single study that shows that psychotherapy kills cancer patients. It does not shorten life. So it's still an active research question, but it may be that active engaged survivorship will help you live longer as well as better. These are 3 kinds of cards. Congratulations, get well, and good luck with the American healthcare system. Physical activity seems to be another kind of survivorship that actually helps people live longer as well as live better. We have found in studies in our own laboratory that women who engage in physical exercise, and it can be just, it doesn't have to be, marathon running like Dr. Love. It can be just regular physical activity, taking walks, is actually associated with longer survival. Another of these grandmother effect things is that sleeping well seems to help people live longer as well as better. So getting a good night's sleep is a very important part of cancer rehabilitation. So in summary, Survivorship 101, cancer is best handled with the acronym FACES. Face rather than flee your problems. Don't pretend they're not there. You can deal with them better if you look them in the eye. Alter your understanding, your perception of what your situation is, and find a new way to think about it. Don't think in all or none terms, my life is ruined or it's not. but how it has changed, what you can do to make it better, cope actively. Find something about the situation you can do something about, express rather than suppress emotion, and seek social support. So we think successful survivorship involves transforming yourself from feeling damaged to feeling that you can transcend. And when you see the winged victory of Samothrace in the Louvre, you don't say, my, there's a woman who's missing her arms and her head. You see it as a symbol of transcendence, and that's what many cancer patients, in fact, learn to do. My French patient said, you know, you have some better days, and she did the typical French resolution of the problem. She made a meal of the crab, and she says, alors, courage. At Stanford, we have a supportive care program at the Cancer Center with special programs for people with various kinds of cancer. We have support groups, classes, yoga. We have a beautiful new health library over at the Hoover Pavilion, and there are many resources available for cancer survivors. We have, there is a chair massage, Pilates, healing touch, a whole bunch of classes for cancer patients you're welcome to come to. We also have a Center for Integrative Medicine that we opened in 1998. It is now over at the Hoover Pavilion in a beautiful new facility, and we welcome you to come there. You don't need a referral. You can refer yourself and come over. We have physicians, psychologists, acupuncturists, massage therapists. We teach courses in mindfulness-based stress reduction, hypnosis. We do treatment with hypnosis, acupuncture, and as I mentioned, therapeutic massage. So we welcome you at the Center for Integrative Medicine as well. In summary, fixing your body can help your mind. Fixing your mind can help your body. Depression and psychotherapy may affect disease progression as well as quality of life. Feeling better may lead to healing better, so mind your body. This is our Center on Stress and Health, a wonderful group of people who have done the research that enables me to tell you what I'm telling you, and I'm very grateful to generations of patients, including a number from the Army of Women, Dr. Love's group, to participate in our research. I am also grateful to our sources of funding, including the National Cancer Institute, National Institute on Aging, and the California Breast Cancer Research Program. Shakespeare said it best, when we our betters see bearing our woes, we scarcely think our miseries our foes. The mind much sufferance doth o'erskip, when grief hath mates and bearing fellowship. But the mind-body relationship is nothing to fool around with. He's saying, what happened to your sergeant? He said, it's a placebo overdose. We're pretty sure he only thinks he's dead. Thank you for your attention.